Okay, it's 12 o'clock. We want to be respectful of everyone's time today. We have quite a full agenda. We're really appreciative that all of you joined us today for our joint media availability. Today, we have folks representing St. Luke's, Saint Alphonsus Health Systems, Valor Health, West Valley Medical Center, Primary Health Medical Group, Saltzer Health, and today Weiser Memorial Hospital also joined us. You have right now your microphones muted. When it comes to the Q&A portion, we will allow you to be able to unmute yourself to ask your question. You'll just need to raise your hand on the little taskbar there so that we can see you have a question, and we'll go ahead and help you unmute at that time. You'll need to actually unmute yourself for us to be able to hear you. You can also enter your questions in the chat feature as well if you prefer. Today speaking is going to be Dr. Steven Nemerson, Dr. Terry O'Connor, Dr. Jordan Blanchard, Dr. William Vetter, Dr. David Peterman, Dr. John Kaiser, and Dr. Richard Augustus, along with Dr. Jim Souza. Again, we will get to your questions as soon as everyone does a short presentation. And before we get started with our planned agenda, I have asked Dr. Jim Souza to speak with you today briefly about what happened this morning in Canyon County related to the Southwest District Health Board meeting, because I'm sure many of you have some questions about that. Dr. Souza, thank you so much for joining us. Go ahead.
Thanks a lot, Anita. Yeah, I'd like to address what happened at Southwest District Health Department today. And I'm going to do my best to keep these comments non-emotional. As we speak right now, in buildings like the one depicted behind me on my screen, our fellow citizens are suffering and dying inside those buildings. And as we speak here right now, our fellow citizens are also doing everything they can inside of buildings and clinics like that to care for their fellow human beings, to ease their suffering and even ease their dying. These people are heroes. They make the world better every day. Our nurses and doctors and therapists and others. Sadly, they're doing this, working the long shifts and the extra shifts, holding the hands of people, toileting people, caring for their wounds in the face of a toxic minority narrative that's actually denigrating the work they do. We're doing, as healthcare providers, everything we can to bring transparency, and we have been. We're sharing data that's validated and given to the state. We've been doing this for 9 months. We're sharing our time and our energy to get the word out. We've even been sharing videos of our staff, of sick and dying patients. Tell us what else we need to provide, and we will provide it. But at the end of the day, it's not going to be okay to have a debate about whether or not the sky is blue or green. And when we have so many people sickened by this in our community right now, and we have people dying from this pandemic inside our buildings right now, the notion that a public health district would give a platform to 2 known conspiracy theorists to share their non-patriotic narrative is unbelievable. A public health district. If science should have any quarter at this time, it should be there. I'd like to know when we're going to stop giving oxygen to those who are trying to say this is either a hoax or no big deal. That there's an effort to take away their freedom. That there is an either or choice. Either we ignore the virus or we ruin our economy. That is complete BS. There is a clear and here. And those of us who work in healthcare have been proving it since the beginning. Our lights are on. As you're going to hear today, our facilities are jammed to the gills. And our people are not acquiring this virus at work. We are proof that there's an and, that when you take care of the public safety, you take care of your capacity for care, and you take care of the economic vitality of our communities. The solutions are simple. They're not an invasion of freedom, and at worst, they're an inconvenience. The morbidity is piling up and the mortality is piling up. And it is time for the quiet majority to take back this conversation. Thanks for letting me say that and address what happened today.
Thank you, Dr. Souza. We appreciate you kind of stepping in last minute to do that and adding that important context for us. So let's get started now with Dr. Steven Nemerson from St. Alphonsus. Go ahead, Dr. Nemerson.
Good afternoon. Thank you for letting me provide this information. And as Dr. Souza referenced, we've been completely transparent with the data that we share. You can look at our website and other public health websites throughout the state of Idaho for much of this information. I'll start with describing in detail exactly what we're facing in our geographic footprint at St. Alphonsus with regard to what we call active cases per 100,000. This is the number of infections that are active and infectious to other people. In the counties that surround all of our acute care facilities, what you'll find is that Ada County is at a record high of over 800 active cases per 100,000. Canyon County over 900 cases per 100,000. Any number greater than 100 cases is considered to be severe COVID prevalence in the community. So we're well beyond severe. In addition, we look at another metric called testing positivity. That is a measure of the people who come to be tested, how many of them are COVID positive. An epidemic is considered out of control if it's over 5%, and our current numbers are again a record high of over 25% at all of our facilities and testing sites in St. Alphonsus. Then finally, let's talk a bit about what we're encountering in terms of inpatient volume. What we know is that patients, people, loved ones in our community who contract COVID, first thing they do is they come to primary care attention, and then in time, usually within 2 weeks, if they're going to require hospitalization, they come to us at the hospital. We are seeing and now exponentially increasing number of patients that are presenting to our emergency departments. Our ER visits are way up, an increase in the number of those demanding testing. It's doubled over the past 6 weeks, and we expect that to continue to grow, obviously. And then of the patients that require hospitalization because they cannot be cared for safely at home, the number of inpatients that we've got currently in the St. Alphonsus system is over 60. And of those 60, 6 to 10 are critically ill at the present time. And that is the greatest number that we've seen since July. And as a consistent trend, it's the greatest number we've seen since the beginning of the pandemic. As also Dr. Souza referenced, and I want to really pay tribute to all of my colleagues throughout St. Alphonsus Health System and all the healthcare workers throughout this state who are working extra shifts, working tirelessly to support now the growing number of patients that have saturated us, caused us to reach 100% of our staff bed census. Right now, 80 of those in our system are on quarantine because they've either contracted COVID in the community or they are suspected to have COVID. And that number 2 for us is a record high. So the numbers are very, very sobering. We see no evidence that growth, that number is going to in any way slow down at the present time. Then let me talk quickly about what our predictive modeling shows. What we see, and it's been very highly accurate over the past 6 to 8 weeks, is that we are expected to double the number of hospitalized patients with COVID by Christmas and triple the number that we're currently experiencing within the next 2 months. Our current percentage of inpatient volume that's COVID positive across our system is about 20% of our patients. That's the point at which we escalate our surge plans for needing to be able to accommodate an extra number of patients in care team ways that we don't usually have to use. And also it's the point at which we have to decrease the care that we're providing in order to accommodate that increased number of patients, which we're doing, and I'll talk about in a second. So that's our current situation at the moment. The prediction of the increased numbers of patients that we expect to see within the next 2 months, and if the trend continues, which we do expect, unless community behavior, particularly the practices of reducing COVID risk, like face covering, discontinuing social events, and distancing, if that does not occur, then we would expect to be in needing to execute our surge plan and use unconventional means for caring for patients in about 2 months' time. What that means is then caring for patients in non-clinical areas, the things that you've seen, worst case scenarios on the news. I want to comment briefly on the stress to our staff. Those that are able to work that have not contracted COVID and will not contract COVID in the community, they are exhausted. They are working longer shifts than they normally would. They are cross-covering for each other, and they have moved into team-based care in order to expand the number of patients they can take care of safely, and that will continue. We at St. Alphonsus have implemented resiliency programming for our colleagues as a result to keep them, their emotional health and well-being maintained. The very last thing I want to comment on is the light at the end of the tunnel. So this is very distressing. It is alarming because in 1 to 2 months' time, we could be in the worst kind of situation that you've seen on the news, with a need to, at that point in time, not only decrease the care that we're providing, which is what we've put in place now by limiting elective procedures and delaying procedures that are not urgent, but if we get to that extreme, actually having to not only limit, but in a sense, ration care. The light at the end of the tunnel is the vaccines that are coming. There are 2 vaccine candidates out there now that look to be safe and highly effective. We believe that best case within the next 2 months, so hopefully by the first of the year, vaccine will be available. Healthcare workers and those with high risk conditions, should they contract COVID, would be prioritized for receipt of that vaccine. But it's critical to understand that the amount of people that need to be vaccinated to protect us all is nationally, it's hundreds of millions of people. Within the state of Idaho, it's several 100,000. And that is not something that we're going to be able to do in one day. It's something that's going to take several months. So we've got to get to the point where vaccine can start to protect our healthcare providers, and then we've got to get to the point where vaccine can protect us all. And what we're asking really is for the next few months to buckle down, follow risk reduction standards that Dr. Souza referenced, and then expect that we are in this yet for a continuing marathon that will go on for several months. And that's what I have to share at the moment. Now I'd like to hand it over to my colleague, Dr. Terry O'Connor.
Great. Thanks, gentlemen, both Dr. Souza and Dr. Nemerson for your comments leading up to this. I will add and open just thanks to the whole panel who are spending some time out of their busy schedules to be here. And I think the unifying motivation behind all of us in being engaged here is we really ultimately are just engaged in giving the best care possible to our communities. And the perspective I bring to this, working in a rural critical access hospital, who also had the misfortune of having to deal with a surge in the early phase of this pandemic, is that it's very clear to me, not only based on the science, but based on real life experience and the stress test that our community went through, that we cannot be good stewards of this problem, of this pandemic, and provide best care possible for our communities without our community's help. We have innovated, we've developed new systems, we are building resiliency, but ultimately at the end of the day, it does take a village to see ourselves through this. Let me just say that back in March and April, unfortunately, Wood River Medical Center, as was well publicized in previous press and stories from our region, was effectively engulfed. I mean, the inferno hit us out of the blue. There was a theory that it could get to us. I don't think anybody really truly believed it was possible that a center could be overwhelmed so quickly, but we were. And despite some attempts at forewarning, I think there wasn't a true vested belief that it could happen to us. But then within a few weeks, we watched nearly 30% of our hospital staff be taken out due to active illness or quarantine due to exposures. We had to close down all of our surgeries, admissions to the hospital, and effectively we became a standalone ER, transferring patients out to our partner hospitals, like our regional hospitals in Magic Valley with St. Luke's and Boise, and also our partners at St. Alphonsus to take the best care possible of our patients that we were not able to admit with their critical illness from COVID here. In addition, with my role as a medical director, engaging with my partners in the EMS and medical transfer arenas to be able to quickly, effectively, and courageously, kind of at a drop of a hat, change their mission and turn into a full, readily available and deeper resource transfer unit to get people where they needed to be in a time-sensitive fashion to provide that best care possible. And back to this analogy of being caught off guard, like being caught in a firestorm in the middle of the night and having no idea it was coming. You know, we've learned now since that experience, we know better how to see this disease coming. We have better testing in place. We have sentinels out on the front to see. We have fire watches looking on the horizon to see that indeed there is smoke on the horizon, and it is indeed coming our way. And it's very unconscionable for someone in my position and anyone else who's had a similar experience like myself, even working clinically and dealing with the critical ill, if we do not spend some time to share our concerns to help prevent the next firestorm from coming, we're just not doing our jobs, and we're not taking the best care possible of our communities. And what I fear is, without taking this time to share our concerns about what's already starting to happen within our hospital capacity, we're just not effectively warning people, and we just need to be in a position that we're giving you the best information we can so that you can be prepared and that we enable you to be good stewards of this problem going forward. Right now, what I've unfortunately been troubled by watching happen over the engagement with my public health partners in the district and vested leadership here within Blaine County is watching our disease rate click and climb steadily over the last month, reaching rates that we experienced within that pandemic wave back in March. And we're also seeing our testing positivity rate continue to climb and climb despite deploying more and more testing. And we are now starting to see it impact our practice in the hospital. As I work as a clinical shift as emergency physician, there's many days I arrive, whether working a day shift or a night shift, and I'll be informed by the chief nurse manager on that I can no longer admit any patients to my hospital. And in addition, that my closest transfer receiving facility in Magic Valley, our sister hospital there, is also on total divert. So I cannot depend on transferring any patients to that location as well. And that has an impact for a number of reasons. And I'd like to just maybe play out just a recent example with some hypotheticals of how this can impact care in a small rural community, even independent of COVID. One, if you have high prevalence of disease in your community, you unfortunately do have to assume that any patient encounter may be with someone that could have COVID. And in the circumstance of a time-sensitive emergency, such as someone calling with shortness of breath in the middle of the night and about to have a cardiac arrest, as we had a few cases just a few days ago, my personnel need to take appropriate precautions because I want them to take good care of themselves, and they have to wear full PPE, and there's protections that need to be put in place before they enter into that scene. And many of them are actually volunteers who are not getting paid, who are going in of the kindness of their own hearts to take good care of their community, but I need them to be safe. That requires them to put on PPE, that requires them to have a staged entry into that scene. And if unfortunately there is a true cardiac arrest going, that results in delays to time on the chest and CPR, which unfortunately is not best care possible. Certainly you would want to get on and perform CPR as early as you can, but there's a built-in delay having to deal about this risk of COVID being. In addition, if you do get a return of spontaneous circulation, you get someone out of that cardiac arrest and you quickly get them to us as a receiving hospital at the closest center, and we find out that they would benefit from getting emergent cardiac intervention to open up, say, a clogged blood vessel. But if my nearest available facility is unable on that particular day to receive that patient in a time-sensitive fashion because they are overwhelmed or on divert due to the burden of COVID illness in the critical care or even in the general ward setting, I may be delayed in getting them to that very effective intervention. And so that I may have to, as a backup, utilize a less effective therapy and buy time. And then also, God forbid, if I have my transfer services already out transferring active COVID patients that need to be admitted to other facilities because we're on divert, then I may have a number of patients that need to find admission to different facilities for emergent surgeries, stroke care, that are getting more and more delays in their care because of hospital capacity issues. And I watch this closely, and increasing at an alarming increasing frequency with each shift, my transfer availability continues to wean down and be less and less and less. I won't belabor too many of the details, but I know that there has been alarm within our system of watching the rates of disease that is inhabiting our ICU setting continue to grow. We also are seeing more employees begin to be sick with this illness, which lessens our capacity to take best care possible of our patients as well. I will just finish by saying that we indeed are spending every moment we can and brainstorming every avenue we can to build in resilience and extra capacity to deliver care. This can even include doing some virtual monitoring of patients that we are watching while they're at home, that hopefully we can avoid from admitting them to the hospital, exploring avenues to do home health checks on individuals in the community, increasing capacity for testing, all of these avenues. But at the end of the day, it seems very clear to me that we do have another firestorm on the horizon. The smoke is blowing in over our community. The flames are not upon us yet. The air quality is suffering. And what becomes very challenging for us and very difficult really to swallow as healthcare professionals is it seems like in some of our communities, we're watching people continue to have bonfire parties in the backyard, just only continuing to contribute and not be good stewards of the risk, but actually making it to some degree worse with their behaviors. And that, although is troubling, we cannot lose heart. And I think we, as healthcare providers, we need to continue to show up and be consistent in this message. And I will thank Dr. Souza again for his opening comments. And I do want to reach out to all those in rural communities like myself. If you are not feeling like you have the respect, if you feel like people don't understand the sacrifices you are making, you're not alone. We all feel them too. You have reason to feel upset. You have reason to feel burnout. But I am confident that when we do see ourselves through this, when a vaccine does become available, when we do have high degree of compliance and buy-in on mask wearing and social distancing and limiting our access to large groups, and when we end up on the other side of this curve and we navigate through this pandemic, it's truly these individuals in our healthcare community, our CNAs, our volunteer EMTs, our paramedics, our nurses, our doctors. It is you who will be lauded as the true heroes of this challenge. And I just ask you all to stick in with it. We'll be there for you. And if we don't continue to fight this fight, I don't know who will. So thanks for everybody for making their time. And of course, I'll be available for specific questions in regards to capacity issues and management of our rural hospital.
Thank you, Dr. O'Connor. We want to go now to Dr. Jordan Blanchard from Weiser Memorial Hospital. Hi, Dr. Blanchard.
Yeah, hi, thanks for letting me be a part of this. So I hope to give a little perspective of what we're seeing or the situation we're in Washington County. Again, a rural health clinic where I work, and then our critical access hospital, Weiser Memorial Hospital, which is a 16-bed critical access. So from a clinic standpoint, we've certainly seen recently in Washington County a real increase, a sharp increase in cases lately. That in the clinic setting, we're seeing much more walk-in or same-day patients, both symptomatic with COVID-19 or seeking testing or screening, more with questions, concerns in that regard. So that's taxed our ability to see an increased volume, certainly day to day. To this point, we've been able to, for the last couple of months, we've been able to do rapid testing, but our ability to continue to get those tests has been quite limited. So recently, we have not been able to reorder rapid test kits, so we'll probably be out of our supply of those tests today. From a hospital standpoint, we've been really fortunate to this point that we have some limits certainly on severity of patients that we can keep here and the number of patients. We've been really grateful that we've still been able to treat patients that need critical care or intensive care to St. Al's or St. Luke's or West Valley. This summer we faced a little bit of pushback with that, and some just here recently as those capacities are starting to be filled up. The example that comes to my mind is we will transfer somebody that's beginning to deteriorate, and we want to try to transfer them sooner than later. And we've still been able to do that, but as I talk with the hospitalists on the receiving end, they sometimes give me the comment that a patient similar to this in the future, if we get more full, you might have to keep a patient like this, at least for a period of time, to save a hospital or a patient bed day on the receiving end. So that's certainly one of our concerns going forward, is having to keep patients that may be sicker than we're used to on this end. One other thing that we're seeing at our critical access hospital is some difficulty transferring patients to rehab facilities like nursing homes, either even just regular patients with heart failure issues or falls and fractures that we typically can provide acute inpatient care and then transfer for rehab. A lot of the nursing homes in our area, as I'm sure is the case throughout much of Idaho, they are dealing with the inundation with COVID-19 cases with their residents, so they're unable to accept our rehab patients. So recently we've been keeping a large number of patients in our hospital as rehab patients, filling quite a few of the beds that we would otherwise have for acute inpatients. So that it causes some concern for us and our ongoing capacity to care for people in our community. Otherwise, we're hopeful looking to the future too with vaccine possibilities. We have some uncertainty going forward of how well that will be accepted in our community, and trying to get a sense of how we can distribute that and what kind of numbers we might anticipate in our community being willing to receive that vaccine, which, just anecdotally, as we visit with people in clinic about that, we get quite a mix of some suspicion and planning to not get that vaccine. But then I'd say a majority so far, in my experience, that have some positive feeling toward it and are planning to receive that vaccine when it's available. So with that, I'll turn the time over to Dr. Vetter, I believe, from Valor Health.
Good morning or afternoon. I'm Dr. Vetter. I'm the director for Valor Health Medical Group. I'm a nursing home medical director. I'm also a full-time family physician. Valor Health is a critical access hospital, as well as we also have a rural health clinic as well, and several other things. We are also suffering from COVID, and we're feeling the strain, and we are seeing the surge. Our urgent care volumes have gone up 200%. Our positivity rate's super high at 25%. We have staff who is not only stressed from working these long hours, but also we have staff out because they're positive with COVID. We are a small health system, and so we don't have much backup. So we've had to close some departments while people are sick. We had to stop some services, whether it's in imaging or other places that we can't do. We are considering stopping surgeries and other things because if those people get sick, we can't do stuff. The things that I wanted to share is, our staff is tired from this, and as I'm thinking more about it, the community kind of depends on us to always be open. And it's kind of like your TV. You just turn it on, you expect it to work. You don't care what happens inside it. And all the CEOs here and CMOs, we know all the stuff going on inside. But right now, with what's going on with the community and the surge we're having and the lack of protection, that demand on us is breaking us. And the community may not see that. So when they turn on their TV or when they come to the hospital or they can't breathe because of COVID or they're having a heart attack, we may not be able to take care of them because either our healthcare providers are sick because they got sick in the community or because the hospitals are filled with people. And that's really hard on a healthcare provider to want to care for somebody you can't. 2020 kind of sucks, but I think what I'm starting to use when we have these discussions, trying to figure out what solution for something, what's the least worst option? And wearing a mask isn't most fun, and my glasses fog up and stuff, but that's the least worst option compared to other things, and so that's what I unfortunately have to deal with. So with that, I'm going to sign off and give it to Dr. David Peterman from Primary Health.
Thank you. I have some slides. It looks like there's some problems with the screen. I don't know if Anita, if they'll show, I can just talk through them. And I'll go very quickly because this has been a long call. And I would just simply say to the media, I've been on a lot of these calls and fortunate, but here is a day to really listen to the physicians from the rural clinics. I purposely chose to practice in a city because I had backup and people could take call. To get the message out is incredibly important about primary care. And that's what I'm covering. But take what I'm saying, magnify it, and that's what these physicians from the rural areas are telling us. So next slide. Thank you. This is, so primary health, we have 20 clinics, they're urgent care, family practice, pediatrics, primary care, over 20 of them throughout the valley. And here's what's happened in terms of the testing. We're up to doing 500 to 600 tests a day and barely able to keep up with that. That tells you what's going on in our community. Next slide. This is the positivity rate. I believe Dr. Nemerson referenced this. You want to have a positivity less than 5%. Positivity rate of both Ada and Canyon County combined of our testing, we've tested over 55,000. I believe this data is extremely accurate. It's 27%. There are very few counties, states in the country that have a positivity rate that high. Once you achieve that rate of a positivity, contact tracing is, in a sense, not effective in terms of slowing down disease. It's effective in terms of protecting individuals, but you've lost that ability when it's that high. Next slide. This is an incredibly dramatic presentation of what's happened in our community. You look all the way back to March and April. All of us were frightened. We quarantined at home. We told our children to stay at home. We told our parents, our friends. Those are the number of positive cases. You can barely see it. Then we had a spike in July related to the bars and restaurants, and that was frightening to us. And we responded to bring that the number of positive cases down, not down as far as we should have. And now look at today. And that line going up is straight up. And the consequences of that, we saw that in the Magic Valley or at the Blaine County. We saw they had to close their hospital. And we've seen Magic Valley and Twin where they've had to shut down or divert at certain times. We're heading in that direction. Next slide. So what's the impact to primary health? So primary care, as you've heard, what we do is see patients to keep you healthy and prevent illness. And then if you have acute problem, your child has an earache, trip and fall and twist your ankle, you come and see us. And the point of seeing us is, one, keep you healthy, take care of those acute illnesses, keep you out of the emergency room, keep you out of the hospital. So what's happened is the community spread has gotten so high in our community, it's impacting our staff and providers. They are not getting coronavirus from the clinics. We have data to support that. They're getting it from being in the community. And what it has occurred is right this morning, I was just notified, we have 35 staff out, and on a daily basis, as high as 5 to 10 providers. At various times, we've had to close 6 urgent care clinics because we were unable to staff them, or we had to shift the people that were there over to our respiratory clinics where we do testing for coronavirus. The problem this creates is if you can't come to those doctors that we just heard from, and you can't come to our clinics, or Dr. Kaiser will tell you about Saltzer. If you can't come to us, where do you go? Your child has an earache. As I said, you have a new not working properly. Where do you go? If you can't contact your primary care doctor? That's how close we are to a very, very difficult situation. And the data that we primary care doctors have and see in terms of the patients is what the hospitals will see in the next 10 days. And again, that's been repeated over and over again. On a normal day in November at Primary Health Medical Group, we would receive 1,800 phone calls a day. We're now receiving over 3,000 phone calls. That means people have to be put on hold. I can't guarantee you that 10 days from now we'll be able to answer every phone call. And this is very concerning. In terms of our testing sites for coronavirus, we're completely booked today. I'm pretty sure we're almost booked completely tomorrow and booking into the next day. The scary thing about that is, and we try to triage and communicate with the patients, we of course don't want someone who's short of breath waiting to get their test. As relates to our staff and our doctors, I'm only mimicking what you've already heard, which is that they are tired, they are working extra shifts, but I'll tell you something, frankly, they don't complain, they just do it. And again, I'm amazed by the staff. I can't not ignore this. What Dr. Souza spoke to absolutely needs to be addressed. And I plead with you, the media, to, if you're going to print what someone says, then you have to follow it up to say it's not true. To even remotely suggest that the mitigation efforts, like wearing masks, causes problems or cause disease, are absolutely ludicrous and should be called as that. And I really implore you as the media, where something is incorrect, either don't print it or put a disclaimer after it. I realize I'm being more forceful than I should be, but we're at a point here where our job as primary care is to keep the patients healthy and keep them out of the hospitals. And we're up against a wall here. So Thank you. Glad to answer any questions and just wanted to update you with where we're at. And now I turn it over to Dr. Kaiser, who has a lot of clinics in Canyon County, and give you a sense of that.
Yes, thank you very much, Dr. Peterman. Do we have that one slide that I sent? If not, it's okay. If not, I'll just go ahead with, here's the slide. So this is our data. This is data for all the counties, but the majority are Ada and Canyon County. Our last week's positive rate was 31.6%. We're on track to exceed that for this current week's data, and that's up from 24% the week before that. Our test volume, we're now doing 1,500 tests a day, where before we were doing 400 to 500 tests a day. And the triage of those patients is just overwhelming our urgent cares and clinics. And so what that's causing us to do is to have to deflect some of that work into our primary care facilities. And that means that that primary care provider can't provide wellness visits, follow up on medications, transition of care for patients who are being discharged for the hospital for various care reasons. So it has kind of a snowball effect on everything that we touch as far as what we should be doing for our patients. The rate of positivity used to be lower for our patients that were in Ada County. This last several weeks, they've been comparable. Both are 31.6 and 31.7% positive. And I don't see a reason for it to turn unless we take things the next step. We all know this is super difficult to do, and it's not part of our nature to try to mitigate these diseases in these ways, but we have no choice. And we are coming upon a holiday season that's going to only have the potential for making it worse. And I just plead with everyone to please try and do the best they can and take that extra effort to protect themselves and to protect others in this new world. Our volume at our clinics that are urgent care, we're now up to, we're now more than double what we saw last year in our urgent care clinics. And this week's volumes will make that triple what we saw last year. And our staff are working unbelievable. They are doing everything they can to try and help. We've brought in extra staff to try and meet the demand. So we're trying to do everything we can to help patients understand the positive, reinforce to them what they need to watch for worsening and what to do to prevent disease spread. So all of that is super important for our community to help get the correct message out there. So I just wish that we could all do everything possible, and we're not there yet, for helping to decrease the spread of this disease in our community. With that, I think I'm turning over to Dr. Augustus at West Valley.
Dr. Augustus is going to join us in just a second. He has some things he can add related to holidays and travel, as a lot of people are thinking about that and making their plans. Until we hear from him, let's go ahead and open it up to a few questions so that we can get started on that. We will stay here with you as long as we can. If our physician leaders need to pop off for additional meetings or to care for patients, we'll allow them to do so. But I want to let our media partners know that we'll try to get as many questions as we can. So if you have a question, feel free to raise your hand. We do have one. We can, Dr. Augustus, thank you so much. Go ahead while we wait. While we hear from him, everyone can raise their hand. We'll start taking notes on who's asking.
So I just second that we are struggling with capacity. At West Valley, we had 100% of our ICU beds used last night. We have 6 ventilators, 5 of them are in use. There is not a whole lot more we can do, and we do not see any decrease in the near future. The patients that we have are staying longer and they're sicker, and we're going to have to make difficult decisions very soon about how we manage those patients because they can't be transferred. I also wanted to talk a little bit about what's coming with the holidays. I had a personal experience My family has been very careful about, distancing. I have an 80-year-old father who I'm concerned about his getting this virus and what it would do to him. And at the end of fall, we were taking a trip to get some wood for them. My mother still likes a wood burning stove, and my dad just wanted to come. He really wanted to come. And so we took him with us to go to the mountain. We weren't seeing anyone, we weren't going anywhere, we just went to the mountain. And my son came along to help us. And my son lives in my house. We didn't think about putting on masks in the truck because we all lived together, except I had my father with me. The day after we returned home, my son had a cough. He was feeling ill. And all of a sudden, I'm worried that we just gave my father coronavirus. It turned out it was a cold. It wasn't the coronavirus, but it could have easily been. And that's exactly the problem, is we get together with our family members, even in small groups. Somebody who does not have symptoms is the one who spreads it to others. It's not their fault. We're not doing something wrong, but we have to be more careful. And we have got to go to a level of extreme that none of us are going to be happy with. As Thanksgiving comes, we can't get together as normal. It's just not possible if we want to have our loved ones safe. And when they try to come to the hospital, we're going to have to make difficult decisions. And as a physician, we never want to see someone that we cannot help. We don't want to do that, but it's getting to the point of capacity. How do we get more nurses when all of our nurses are working extra shifts already? How do we get more physicians? How do we provide more ventilators? We don't have them. We have to do something different, and these numbers are terrifying. And it's real, it's not made up. This is simply a fact. We have to change our behavior. And I don't like the government telling us what to do. It needs to be personal responsibility, but people aren't listening. You have to listen and change your behavior, or we're going to be in trouble. Anita, that's all I have.
Thank you, Dr. Augustus. We'll start with Rebecca Boone, who has a question. Go ahead, Rebecca. Please make sure to unmute yourself. Thank you.
Hey there. I have a question for Drs. Nemerson and Souza. Do the predictive models at your facilities include expected travel levels during Thanksgiving, or are those based on the current rates?
I can speak first, Dr. Nemerson, St. Alphonsus. No, it doesn't include predictive uptick in the holidays related to travel and family gatherings, and particularly social gatherings with people outside the nuclear family. So that's even more alarming to us, that the situation would be worse than our predicted scenarios.
We're in the same boat. Current models don't account for that. We have a tool that is applying machine learning, so it will learn some things about this upcoming holiday season. It hasn't learned it yet.
Thank you. Scott Logan from KBOI also has a question. Scott, we'll need you to unmute yourself so we can hear you.
Okay, can you hear me now?
We sure can, thank you.
This is for Dr. Souza, sir. I was struck by what you called the toxic minority narrative. It seems a repetition from all learned folks is that half the community, or I don't know what, they're letting you down, letting us down, because it's become political. Did you ever dream that this would become such a political situation?
No, I didn't. And you know, of course, I think I finished my comment by saying it's time for the quiet majority to take back this conversation. Because when I walk around our city, when I go to stores, working with the people I work with, I know that most people either are doing the right thing or want to do the right thing. And some of them want to do the right thing, but they're not sure. They actually just need more information. The toxic minority I'm talking about is frankly just tweeting, retweeting, forwarding conspiracy theories from the internet. And, you know, again, I would ask how much more transparent we can be. Sign us up, we'll do it.
So this is Dr. Bill Vetter from Emmett. I'd like to add some comments there too. I'm in Emmett, and I feel kind of scared if I actually say what I feel, and that I may have harm to me or to my family or to my property, since we're a small community in Emmett, and the vocal few may try to stifle that, and they kind of have. So I just quietly do what I do, and become the silent majority, unfortunately.
Our next question is from Rachel at KMVT. Rachel, you'll need to unmute yourself, but go ahead.
Okay, so this is for Dr. Sousa, but any of you guys can answer this. How are you guys, getting prepared for flu season in the colder months while COVID cases are continuing to spike?
Why don't I turn it over to the rest of the group?
Feel free to have anyone weigh in on that one, since it impacts you all differently.
Yeah.
I'll start. Nemerson, St. Alphonsus. So we're initiating all the things that we would routinely do during flu and adding them on top of COVID. And so that anticipates an uptick in influenza. The first cases have already been reported in our regions, but they're very few, and we would expect peaks to occur after the first of the year. So we're doing that. We're highly encouraging and making flu vaccine accessible to everyone in the community, because getting COVID and flu, either one after the other or together, could be a deadly combination. We know this. And the last thing I would say is it's critically important to realize that the protective measures for COVID are the same as they are for influenza. So people who conform to those face covering and distancing measures will reduce their risk of getting flu significantly. And fundamentally, this is really a primary care issue. And when we think about that and primary care being overwhelmed, helping patients to protect themselves from getting flu and their families, it becomes a problem.
Rebecca Boone also has an additional question. Go ahead, Rebecca. You'll need to unmute yourself as well.
Hi, thank you. I'm just wondering if anybody can put into sort of layman's terms what rationing care actually would look like in practice. So there's a lot of metrics I know on some of the state documents that are out there, but if you reach the point where we need to ration care in our hospitals, how do we describe that to readers in a way that they understand? What would that look like?
I'll take that from a rural health perspective. The answer is sorry. There's nothing we can do. And it kind of sucks. There is, there's, and I'm sure the bigger hospitals have protocols on if we have two people that need the ventilator, who's going to get it. But from a rural perspective, we don't get those options. It's more, I'm sorry, the line's full, you can't get it. And so whatever life-saving thing you need, whether it's delivering a baby with a C-section, heart attack, ventilator, or whatever, you're not going to get it. So that's my rural view. I'll let the Boise hospitals talk.
I can,
Yeah.
go ahead, Jim.
Yeah, we've got a plan to implement the state's crisis standards of care if we needed to. Those crisis standards of care call out basically an assessment of the patient upon entry to determine whether or not they qualify for a trial of critical care. If they qualify and they receive that trial of critical care after a certain period of time, they're reassessed and they're scored against other patients who also might need that critical care bed. And the individual with the greatest chance of survival and years of survival is allocated the resource. I think we're all coming to the conclusion that for most of us, it won't be supplies, right, that limit this. It won't be like number of ventilators. It's going to be staffed beds. So we would adhere to the state guidelines in terms of the crisis standards of care. We'd collaborate with others across the region, and then we would apply those guidelines with triage teams. Totally preventable, 100% preventable scenario. We just have to act.
And I think connecting the dots. So the other thing I would add is it starts at the front line, calling an ambulance. So people need to understand that ambulances don't just come to your home and take you into an emergency department. They also transport patients between nursing homes and hospitals, and they transport patients between hospitals, which is something that we are already doing as we are moving patients from one hospital that's full to another hospital that has a little bit of space. And so we would expect that if we reach crisis standards, the response time for emergency medical teams would be delayed. Then they may need to make decisions about who they actually code, who they actually resuscitate on scene, because they may or may not have a place to take the patient to if the emergency room is completely full and overflowing. Assuming that the patient can come to the emergency department, then we will be in a situation where we can't get patients into regular beds with the same timeliness that we're able to. So that would be delayed. And then to what Dr. Souza was pointing out, we would implement our protocols for determining which patients that reach the hospital receive resuscitative care, and then which of those patients that receive resuscitative care succeed in a critical care trial should they need that. It's really horrific to conceive of, but it's a very real possibility within the next, say, 2 months, if not sooner.
Dr. O'Connor also has his hand raised. Go ahead, Dr. O'Connor.
Yeah, Rebecca, I would just maybe reference back to some of my examples from before. I think when we use this term rationing of care, it's a large spectrum, right? And we've been focusing on, because it is alarming and it's it quickly captures the attention to think about crisis standards of care, but we're already rationing care right now, right? I mean, we are anticipating and seeing that we are going to have a surge in demand in our inpatient centers in settings, and we may not have enough beds or staff to accommodate for that. So we're in a position right now where we're rationing care by no longer scheduling elective cases that require an overnight stay. And some centers are already having to cancel surgery. So you may have had a surgery scheduled to have a knee replacement for chronic knee pain that's been debilitating you in your daily functioning as a carpenter or as someone in the community, and you've been waiting for 4 months to get your knee replaced and your surgery just got canceled. You may be a woman who's been dealing with intermittent pain from a symptomatic gallbladder who had been scheduled to get a surgery, have that taken out, so you no longer have to deal with that pain. And unfortunately, your surgery might get canceled because we can't recover you in the hospital and take that bed because we've got to conserve it for the surge that we anticipate coming. And then in the acute phase, what someone like an emergency provider or any of my emergency personnel hate having to swallow is this concept of getting to the scene to manage an acute heart attack and then finding out that we do everything along the chain, but then the final step to provide definitive care might be compromised because the critical care capacity at our referral center that does that cardiac intervention is effectively rationed because there's no place to admit that patient because of care. So it's already happening. So I think we already have a sense of what that looks like.
Thank you, Dr. O'Connell. Rachel Cohen, you go ahead and ask your question. Please unmute yourself. Rachel, we can't hear you if you're speaking. We're going to come back to Rachel. Les, you also have a question. Go ahead and ask that, but we'll need you to hit the unmute button so we can hear you.
Yeah, good afternoon. In the range of public health crises, you all talk about we need to talk to the public in clear, plain language. Bottom line, tell the public what you are dealing with here. Are we dealing with a short-term public emergency? Do you describe this as a public health crisis, a community crisis? I mean, let's tell the community very directly how you overall assess where we are and where we're heading.
This is Jim Souza. This is a once-in-a-lifetime event. I think in the experience of the physicians on this call, never in my career did I think we would even contemplate the idea of rationing care in the United States of America. Never. At the beginning of the pandemic, when we developed these plans, I thought to myself, well, it's good that we're doing that in case there's a mass casualty event or something else. Long about early October, I started to get worried that those plans were actually well conceived and might be needed. And while I'm still reluctant to say it's more probable than not that we exercise them, I think they might be just in time. Can't believe that.
Dr. Nemerson, St. Al's. I like the term that I've seen others use. It's a humanitarian crisis. Let's talk about our employees first, who are witnessing death every day, who are under the most stress that they've ever been in the work environment, and then they need to go home and experience the same things that everybody else in the community is experiencing. And so that's emotional and physical trauma to the people who are required to give care to the rest of us and be there for the duration of this pandemic. It's incredibly troubling. Then the addition is the people who are victims of the disease directly, who are dying or are hospitalized and then debilitated for months, if not permanently thereafter. They may be the vast minority, but we've never had to deal with an infectious disease that's caused this degree of harm and disability long term. And then finally, there's the rest of us who will or will not contract the disease and will recover fully. And the conflict that it's causing within our community and the fact that we've taken an infectious disease and made it into a political and emotional issue for all of us, which is a great tragedy. So that's how I look at it.
Thank you all. I want to be respectful of time. I just appreciate all of you openly and honestly sharing with us and conveying this information to our community. If you have further follow-up questions that weren't able to be asked here, please send us an email and we'll see if we can track down an answer for you. Appreciate your time. Have a good day.